expected to be infected with Ebola in Africa by January of 2015, based on the CDC's worst-case scenario.
Oh my gosh, didn't I say something like 4 million? They're talking about 1 million.
The worst case scenario.
That's a lot of people that actually be infected. So do you know about what percentage of people with Ebola die? 50%, yeah. So if the worst case scenario would happen, about 700,000 people in Africa will die.
How is Ebola transmitted from person to person?
Think about bodily fluids.
Just learned that today.
If someone with Ebola coughed on you, would you contract it that way?
No.
What are the steps necessary to contain Ebola?
I mean, but
All right. Hi, welcome everyone to our Ebola discussion panel presentation. My name is Molly Teague, and I'm the president of United Against Inequities in Disease, which is a public health organization on campus. And we decided to have this panel because, as you all know, this is a hot topic right now in the news, and so we thought it was important that even though the United States isn't as impacted by any stretch of the imagination as other countries throughout the world right now, that doesn't make it any less important for us to be informed and to be educated about something that's having such an effect on the world right now. And so we thought it'd be interesting to get perspectives beyond just how many people are gonna, get Ebola, how many countries is it gonna spread to, different things like how does it affect the economic development of countries? How do you, when you see those numbers of, 25% of cases are going to do such and such, where do those numbers come from? Things like that. So we got our lovely panelists that are going to talk to you about that. So how this is going to work is we're going to have a brief presentation at the beginning where each of our professors is going to talk a little bit about their area of expertise in relation to Ebola, and then we're going to open it up to questions and more of an interactive panel question-answer discussion. And then I encourage you to stick around. At the end, we're going to have beverages and snacks and whatnot. I encourage you all to stay and mingle and talk to the professors if you have any more questions. And so who are our experts? So first we have Dr. Camilla Buchanan from the Kinesiology and Health Sciences Department. She got her Bachelor's of Science in Chemistry here, actually, and then taught chemistry and physics for several years before going to med school, and was a licensed OBGYN, and then went and got her Master's of Public Health from EVMS and ODU, and is a diplomat of tropical medicine and hygiene after studying at the London School of Hygiene and Tropical Medicine, which I think is very cool. And her focus is on children and women's health, specifically in Kenya, and here on campus she teaches global health courses. Then we have Dr. Alison Scott, who I think many of you are her students here today. She's also from Kinesiology and Health Sciences. She got her undergraduate in microbiology from UMiami, and then went and got a master's in medical microbiology and immunology from University of Wisconsin-Madison, and then got a master's in international health, and then a PhD from Johns Hopkins. She looks at social determinants of health and specifically vulnerable populations, and teaches Intro to Global Health, Social and Behavioral Science in Health, and other courses like that on campus. Next, we have Dr. Leah Shaw from the Applied Sciences Department, who got her undergraduate in physics and math at Virginia Tech, then a master's in math at Virginia Tech, and finally a PhD in physics at Cornell. And she uses math and physics to model the dynamics of biological systems, and specifically epidemiology and ecology, and here on campus teaches classes like population dynamics and random walks in biology. Last but not least, we have Dr. Admasu Shiferaw, who is economics and Africana studies, and got his undergraduate in agricultural economics from Alamaya University, and then a master's in developmental economics at Erasmus University at Rotterdam, and a PhD there as well. He looks at the infrastructure and developmental economics of African nations. And here on campus, he teaches courses in developmental economics, African economic development, labor markets, and entrepreneurship. So we have a very diverse group of perspectives here, and I'm as excited as you all are, I'm sure, to hear what they have to say. So I'm going to open it up first to Dr. Buchanan and Dr. Scott.
made Dr. Scott do all the work because the slides are hers. And I was going to add slides to it, but her slides were so good, I thought, why do that? So we're going to go through her slides, and if I have anything to add, I will, but I think that the slides may speak for themselves.
Okay, I'm happy to be here tonight, and I see a lot of students who are in the global health class, and in that case, you can take a little snooze during this piece, because we've been discussing this all semester. But so I hope you're going to hear this, and it's all going to be old hat. But Camilla and I are going to go through some of the public global health and actually also domestic global health issues related to Ebola, and sort of lay the foundation for some of our discussion and the other talks. We thought it would be appropriate to start off with a little bit of virology. And I know some of you will be vastly interested in the virology of this, and some of you will be vastly uninterested. But suffice it to say, it's Ebola virus. There are 5 different viruses, actually, that sort of make up the family of Ebola viruses. What we'll be talking about mainly today is the one at the top that originally was called Ebola Zaire, because that's where the first cases were discovered. But now we simply call it Ebola virus most of the time. And most of the time when we have epidemics, this is the strain we're talking about. You'll see at the bottom there, the one in parentheses, the Reston virus. If you read the Hot Zone, the Preston, is that his name? Preston book about the outbreak in Nova. Luckily, it turns out that Reston virus attacks primates but not humans, which was a stroke of good luck there in the late 80s. This is an electron micrograph of an Ebola virus. If you got to look through an electron microscope, this is sort of what it would look like. It has this characteristic, what we refer to as a shepherd's crook shape, or sometimes it just looks like a coil or an L. It's a fairly simple virus. It's only 7 genes, quite small. And the reason I say this is twofold. Number one, because that's an interesting fact. But number two, because as viruses go, it's actually not a terribly complex one. There's a lot more complexity, however, to trying to work with it in the lab, as you can imagine. It's a linear, non-segmented, single-strand RNA antisense virus, if that's something that is meaningful to you. When we talk about transmission, we're especially interested in knowing, for example, that it's non-segmented. It's not like, say, an influenza virus. And when we talk about influenza, of course, we worry about the virus changing from year to year, and that has to do with segmentation, so we can talk about that more later. And the picture at the top is the Ebola River in the Democratic Republic of Congo, which used to be Zaire, and this was near the area of the initial outbreak in the 70s. A little bit about how the virus works and the pathogenesis it causes in the body. I don't want to spend too much time here again, because this isn't really a microbiology lecture, but I want to make a couple of basic points about the virus that are important. The first one is that one of the reasons that it causes such severe disease is its ability to infect lots of different types of cells in your body. It can infect different types of organ cells, kidney cells, liver cells, and as part of that, contribute to organ failure in the end stage of the disease. It can also infect different types of immune cells, monocytes, macrophages, dendritic cells, neutrophils in some cases. And that can serve a couple of purposes, or lead to a couple of outcomes. Not only can that hamper your immune response to the virus, it can also contribute to the spread of the virus all around the body, so simply put. In addition, endothelial cells are targeted by Ebola, and endothelial cells are the cells that line all of the different blood vessels in your body, and this is really important for the characteristic symptoms we see of Ebola that involve bleeding and clotting and hemorrhaging. The virulence we see with Ebola, which is extremely high, and by virulence we mean basically disease, severe disease, and in many cases death, have have to do with a number of different factors, a number of different things that happen as a result of Ebola infection. Again, we have infection of so many different cell types, and once the cells are infected by Ebola, the virus is very prolific at reproducing itself. And that can lead to, not surprisingly, death of cells that it infects, and a lot of sequelae that come from that. But in addition to the direct effects of the virus itself and the pathogenesis that those cause, we also have this issue of problems and symptoms that result from your body's response to the virus. Your own immune response, for example, can cause things like inflammation, cascades of different cytokines that can actually contribute to some of the symptoms and progression of the virus.
Yeah, so Alison really stole all my thunder here, because this would be what a physician would talk about, the pathophysiology of the illness. I think something that I read the other day that really struck me was Paul Farmer, and most of you all probably know of Paul Farmer from Harvard University. He has been quite the spokesperson for underserved populations, and he said that in his opinion, in spite of the fact that this is a very virulent virus, that with proper 21st century medical care, that the case fatality rate of this virus, viral infection, should be much less than what we're seeing currently, which is around 50%. In his opinion, it should be much like 10%. And that has really been borne out in those people that have been evacuated to high-resource countries. They have, for the most part, survived, particularly when they have been hospitalized early and had the benefit of early care. The other thing I wanted to say is that as the disease progresses, the viral titer increases remarkably, exponentially. And so the most dangerous person to infect you is, in fact, the dead person, the corpse, because that has the highest viral titer.
Okay. All right, so I think we all know a little bit about the most typical syndromes or symptoms that are associated with Ebola, but let's just sort of walk through the typical sequence of events. The first symptoms that Ebola infection tends to involve are fairly non-specific, sort of general, what we would call flu-like symptoms. Fatigue, fever, the sort of aches and pains that you get when you have practically any sort of viral infection. And this can be up to a week to 9 days after you've been infected. And this presents a lot of trouble, a lot of problems for clinicians, for public health workers in the field, as you can imagine, because if someone presents to you at a clinic with fever, with aches and pains, with headache, you have no idea what that is. It could be Ebola in a setting where you have an Ebola epidemic going on. Of course, that's going to be something you suspect. But in a lot of these places, it could be malaria. It could be other sorts of hemorrhagic fevers. There are all manner of things that could present in this way, and that's presented a real challenge to achieving early diagnosis of cases. But we'll talk a little bit more about that later. As you move into the second week, you head into the territory of more severe and systemic symptoms where the fever spikes. You start to see vomiting and diarrhea. And then as you move forward pretty quickly, you start to see some of the bleeding symptoms and the edema, internal bleeding, organ damage, and often by, again, depending on the setting, can lead to death by the end of that second week. Okay, so how is Ebola transmitted? This was an open question for a long time. We really didn't understand why all of a sudden in these very rural and remote areas you would see these horrible outbreaks of this hemorrhagic disease. But of late, there's an emerging consensus and growing evidence that certain types of bats serve as reservoirs for Ebola viruses. And when we say reservoir, we mean that that's an animal that can carry the virus without becoming sick itself, to sort of serve as a home for that. And so these bats live in a lot of Ebola epidemic areas, and in some cases are sources of bushmeat for people who live in the area. And so there are a few different transmission cycles that are possible. You can either have, in this case, what we think happened in Guinea, direct transmission from a bat to a human if a bat is consumed, again, as a source of food, or there's some sort of encounter someone has with a diseased bat that allows the virus to get introduced. Or you can have this intermediate cycle that goes on where a bat actually infects some other sort of animal, another primate, for example. And then that animal comes into contact via, again, being bushmeat or in some other way with the human and sparks the epidemic that way. And of course, what we know of Ebola is that once it's introduced into a human population, the human-to-human transmission is highly successful and highly efficient. And that's usually then how the epidemics are perpetuated from there. Okay, so transmission. This is a real million-dollar slide here that I think all of America needs to spend a little time with. How is Ebola transmitted? Ebola is transmitted, again, by direct contact with bodily fluids. That's sort of an amorphous term, so let's list all of the body fluids we can think of. The three that are going to be most important, we're talking blood, we're talking feces, fecal matter, vomit. We also need to think about breast milk, semen, spit, and urine. That, again, someone who's infected is currently suffering from Ebola disease, or as Dr. Buchanan pointed out, has died from Ebola, are wonderful reservoirs of Ebola virus in all of these ways. And again, people who have died have the highest viral load and are thus more dangerous than ever for transmission. Because of this route of transmission, what we know is that the most danger is present to people who come into direct contact while caring for people while they're sick or after they've died. And so we're talking mainly about healthcare workers or family members and friends who are caring for people who are sick in their homes, which is a lot of the cases in these countries right now. And in addition, people who are involved in burials, where there might be some contact with the body that is involved there. I've heard various people speculate that, if they're infected, they have these strange burial practices, and that's ridiculous. We all have burial rituals that we go through and that are very important to us, socially and culturally, and that varies from family to family, but that is true in these areas as well, and so sometimes that can present opportunities for transmission, unfortunately, so that's something we have to be aware of. And I want to emphasize for the first time here, some of you might have friends on your Facebook page who keep insisting that Ebola is airborne, that something has happened. I even had a physician tell me the other day that Ebola could be transmitted via the air. And let me say emphatically that is not true. That isn't to say that if you're taking care of someone with Ebola and that person sneezes on you and a big glob of spit hits you in the face, gets in your mouth, gets in your nose, that you can't be infected that way, because you can. But again, as we talk about in global health, we have to be very, very careful when we throw that term around. When we talk about something being transmitted through the air, what we're talking about is viruses hitchhiking on microscopic particles of spit, in essence, and floating around in the air in the room, sometimes for long periods of time. And that is not the case with Ebola. And actually, in some ways, the various bunglings that we've had in our early dealings with the virus in Dallas, especially, have proven that point, have brought that to bear. But we'll talk about that a little more later.
Oh, just that, there was very early in the epidemic, there was a UN worker who fled from Sierra Leone to Nigeria to get better medical care. He had family in Nigeria, and he was really quite ill when he boarded the plane and landed in Nigeria. And the 200 people that were on that plane all remained Ebola-free. So it is not that easy to transmit this virus unless you have direct contact with someone. You have to actually be close to them. You have to be touching their skin, okay, like this. If I'm standing here, it's okay. And the Centers for Disease Control actually have a way of categorizing risk of people who have been in Ebola endemic areas or in the epidemic area as it is, and we hopefully will see that a little bit later.
Okay, how do you diagnose a case of Ebola? Unfortunately, not easily is the basic answer to that question. If you are in a modern facility, you can do a polymerase chain reaction and look for RNA of the virus. You can do an ELISA test. Later on in the infection, you can try to detect antibodies. You can look for it under an electron microscope. But as you can imagine, in a lot of settings, these things are just not an option. Or if they are an option, it requires taking a blood sample that, you know, is a dangerous prospect in and of itself, transporting it over badly damaged or not present roads, maybe in vehicles, maybe in not, to some sort of urban center where they have a testing facility, waiting for those results, and then managing to communicate those results back to a clinic. So definitely not an easy thing to do. So again, we have this difficulty of figuring out, making diagnoses in an expedient manner, trying to differentiate cases that appear from all of these other diseases that can look quite similar. There is some, I'm guessing this is about what you're about to say, work that's going on to try to develop a rapid test, something that you could use at the point of contact with a patient that would just require maybe a few drops of blood on a slide or in some sort of test, so you would know immediately whether that person was Ebola positive or not, and that would be a tremendous help.
The best thing the U.S. Navy has done is with the new mobile hospitals that they're setting them up with labs so that on site they'll be able to do the testing for Ebola. And that is going to rapidly speed up those people that are being incubated to see if they actually have Ebola or not. So if they test negative, they can get them away from the rest of the people.
Right, because you think about the consequences of this, and we'll talk about the different treatment types of settings in a minute, but if you have someone who reports to one of these clinics, for example, with fever, you know, you need to be better safe than sorry. So you assume that person has Ebola infection, and you put them in a lot of cases with other Ebola positive patients. But what if it turns out that person actually has malaria? And they're in, for multiple days, in close contact with all of these Ebola patients. You know, even by the time that negative test comes back, that person now will be positive. So it's vitally important. Okay, treatment. And this is another arena of bad news. We don't really have good treatment. Supportive care is the euphemism we use. We try to provide people rehydration, you know, ORT or IV fluids if we can. But again, the use of IVs has a lot of risk for healthcare workers. Painkillers, antibiotics to prevent secondary infections. If you have the facilities, sometimes you need transfusion to deal with blood loss, dialysis to help kidneys that might be struggling. Do you want to add any to that piece?
No, just keeping the blood pressure up. What happens with the leaky capillaries, the liquid from the blood goes out into the extracellular fluid area, and the blood pressure drops, and people die of organ failure from low blood pressure.
We do have a number of experimental drugs and vaccines that are out there. You may have heard at the beginning of the epidemic, or not the beginning, but a few months ago in the epidemic, the use of ZMapp. ZMapp is an experimental drug. It's a cocktail of 3 different monoclonal antibodies against Ebola that has shown pretty good efficacy in primate testing in the lab. It's not something that has been tested in humans, but we evoke what we call the animal efficacy rule in these situations that say, well, we know it's not tested or approved, but the situation is so dire and it works in animals, so we're going to give it a shot. And there were a lot of ethical dilemmas around using the drug. We only had like a half dozen doses. So when to use it, who received those doses was controversial, but but at this point, those supplies are exhausted. But it's pretty amazing to see now, if you look at the Wikipedia page, which is actually pretty good, the number of drugs and vaccines that all of a sudden, just in the past month, have been catapulted into production and into trials. And this is a testament, I don't know how to say this, a testament to the resiliency of science on one hand, but also to the cynicism of these things. The fact that we really hadn't rushed along on any of this in the past because it wasn't deemed a threat to those of us who had money to pay for drugs and vaccines. And now suddenly it's scary to us, and so suddenly the science moves. So unfortunately, this is the case in a lot of diseases that afflict poor and marginalized people in the world, that they aren't a very good market. And so we don't really bother to invest our time and money to develop drugs and vaccines until we have some motivation of our own and some market that can be gleaned from that. Oh, I'm sorry, I'm going too slowly. Okay, prevention and control. Primarily, we need to isolate our cases. I think we all know this, and so as a piece of that, it's vitally important to have protective gear for healthcare workers, make sure we sterilize all of our equipment. Safe handling of bodies after people are deceased is so important, and so all of our procedures for disinfection and incineration become critical. Contact tracing. Outside of the clinic, this is our primary method of control in the community. And that's basically this idea of figuring out everybody with whom an Ebola case has had contact, and then basically checking in on those people every day for 21 days to make sure if they develop symptoms that they are isolated immediately so they can't infect anybody else. So the idea here is that we need to break the transmission chain. Okay, a few things that are not effective as prevention and control techniques. Firing teachers who have visited Kenya for a few weeks and returned home. If you, I hope, will look at your map of Africa and see that that's pretty absurd. Rejecting college applicants because they live in Nigeria, or taking nurses that have returned from fighting Ebola and quarantining them in tents outside of hospitals in New Jersey. These are not effective. Okay, so a few more specifics about the West African outbreak. And these maps I just want to use to give a little bit of perspective. In America, we tend to do this thing of assuming, number one, that Africa is a country, and number two, that Africa is small. And neither of those things is true. This map I like because it superimposes the continents of China, India, the United States, and a number of other countries all on the continent of Africa to give us some sense of size. And this map is nice in sort of labeling where the Ebola is and where it isn't, and you can see that where it isn't is rather large. Okay, so history of the outbreak. This goes way back to December of 2013. It started in Guinea, and the guess is that it was a 2-year-old boy who lived in a rural community that was the first case. And his family had a history of hunting bats for bushmeat. By May, it had spread to the capital of Guinea. By June, it had crossed over the border. We're way over here on the west side here, and these borders are all close to one another, into Liberia and Sierra Leone. There was a case that was imported into Nigeria in July, but as of October, Nigeria is Ebola-free. They use these principles of contact tracing and isolation, and they eliminated their cases. Senegal, they had a case that came in by land. They also have eliminated all cases. Okay, and I won't spend much time here because this is Dr. Shaw's area. This is just the number of cases that we're seeing, just exponential growth. But we see these numbers on CDC sites, and then they tell us that they're crummy. These are vast underestimates for reasons that will be discussed. Okay, and this is a map sort of showing where we've had cases so far. All right, so what are some of the contributing factors in West Africa? And again, we'll hear more about this, so I'm not going to spend much time here, but these are contexts of tremendous poverty, and the lack of infrastructure that's available there is a key part to enabling the transmission and the spread of the virus. And in addition, 2 of the 3 countries, Liberia and Sierra Leone, have a history of conflict that plays in. In addition, one of the big differences now compared to prior outbreaks is that we have spread in cities, whereas before things were pretty much confined to rural areas. Okay. In addition, this is an area where we haven't seen Ebola before, and so that slowed our response in some areas. In addition, there's been a lot of critique of the international community's response, or lack thereof, early on in the epidemic. A few more things, and this is such a laundry list, sort of a perfect storm of things that have gone wrong. Again, because things got out of control, our ability to bring things, bring things under control using contact tracing, we really lost that ability because the virus started to spread so rapidly. In addition, we're talking about an area where we don't have healthcare workers, we don't have clinics that have supplies, adequate facilities, even in some cases things like electricity or water. In addition, when we're trying to go in and expand some of that infrastructure, some of the healthcare infrastructure, those efforts are being impeded by the lack of other sorts of infrastructure, whether that's roads or airstrips or water sources or construction equipment, and that's making the scale up increasingly difficult. Okay, so what is our approach to control right now? And I want to highlight this because I know it will come into play later. It's a fairly, it's a hard thing to swallow, but our goal in some of these settings, especially this is in Sierra Leone that I took this information from, is to try to minimize what we refer to as R. And R is the rate of reproduction of an infection. It's essentially if you have 1 case of Ebola, how many people does that case infect, and so on and so on. If rate of reproduction is 0, that means you've stopped things. So basically our efforts in some of these communities now are focusing on trying to minimize R. And so at the tip of that pyramid, we have people staying in ETUs, or Ebola treatment units, where they're actually getting some care from healthcare personnel. But beneath that, we have an even bigger group of people who are being treated in what we refer to as Ebola community care clinics or community care units. And these are essentially tents that are put up in towns. In some cases, there's a wet tent and a dry tent. So the wet tent would be if you're having symptoms of vomiting, diarrhea, things like that. You'll have a water supply, a couple of latrines, so a place to burn things. This is not staffed by physicians or nurses necessarily. Oftentimes it's going to be volunteers, hopefully people who have survived Ebola, so who might have some immunity, but in some cases not. They're just volunteers and low-level health workers with very limited training, very limited protection. Very limited care here, antimalarials, maybe some rehydration, antibiotics, food, things like this. It's acknowledged that a lot of the volunteers who work at these places will probably get infected themselves. The last 2 tiers of this pyramid, however, and this is the majority of the cases, it's just understood that in a lot of contexts, people are not receiving any care. They are going to be cared for by people in their homes. And we're going to do our best to provide them things like gloves and masks and oral rehydration and maybe some bleach. And they're encouraged to put the person who's ill in a room and have just one person care for them independently. And again, the idea is not to save that person, the idea is to minimize transmission, that if only one person takes care of the case, ideally only one more person will be infected. This is a picture that just came out yesterday from CDC of one of these community care centers in a community in Liberia. So again, you can see this is not exactly a high caliber institution. This is just a place essentially to quarantine people to try to reduce the number of new cases that result. But of course, for obvious reasons, there's fear of going to these centers, distrust of governments and authorities that relates to the legacy and the history and the politics in the area. Of course, while all this is going on, we have collapse of healthcare systems, all of these other health problems in the area that are not being addressed, impact on economies that I won't discuss. Okay, a little bit about Ebola in the United States, and I hope we all know this. We've had a number of cases that are people who were infected while working in the field who have come home and recovered. We had one visitor from Liberia, and I think we all know the Dallas case, who reported to the ER with symptoms of Ebola and was sent home. Stayed with his friends and family for another few days before coming back to the hospital and subsequently dying. And those are the only 2 instances in the US of what we would call local transmission. That 2 of the nurses who cared for this man in Dallas were infected. And again, to shore up one more time Camilla's point, all of the fear that we've had, the subway, the cruise ship, bowling, all of the ways that we were so scared about. The only cases of transmission that we've seen have been nurses who were caring for a patient who was vomiting, having diarrhea, and there's some evidence that those nurses were not adequately protected while they were doing that. Okay, so this is what Camilla was referring to, that the CDC's policies for surveillance establishes 3 risk categories for people who have been exposed but don't have symptoms. So for example, we're talking about the nurse who's been in the news, Casey Hickox, up there, who was the one in the tent and is now blessedly out of the tent. So as part of these risk categories, people can be monitored. We have either what you call active monitoring, where people are monitoring their own temperature and symptoms a couple times a day. We also have what we call direct active monitoring, where someone from a public health department will actually go on a regular schedule, take the temperature of the person themselves, and do an examination. We also have different levels of travel restrictions, what you're allowed to do in town. For example, someone at high risk might be able to go into town, but will have to keep a 3-foot barrier between herself and anybody else in the community. Of course, we do have some states, some governors who have added more stringent criteria, but this is the set, I hope you would agree, that are sort of the evidence-based and quite conservative already set of criteria for surveillance. So we've had a number of embarrassing debacles related to Ebola in the US. There was the mishandling of the Dallas case. It's exposed a lot of gaps in our preparedness and questions about risk that have come up. The media has not helped in many ways. And sometimes, in some cases, the Ebola thing has sort of played into politics and campaigns for midterm elections and things like this, and has fostered this sort of inaccurate sense of risk that a lot of people in the US have. Okay, this was just a quote I really liked that sort of brought this point home. This is Dr. Les Roberts, who's an epidemiologist who was at Hopkins when I was a student there. Now he's with Columbia, but he's in Sierra Leone directing the foreign medical teams that are there. And he's been keeping a blog about all this out of Sierra Leone and documenting these horrible things. And he wrote on the 27th, he said, "There's grim news to report from the vantage of Freetown. There is a deadly outbreak threatening worldwide safety, an outbreak of unadulterated insanity in the US. I fear we will not be safe from the scourge until a vaccine is developed that can prevent governors, unencumbered by scientific evidence or logic, from becoming infected with presidential ambitions." That was quite good. So I'm sorry if I've gone on too long. I'll pass it off.
Thank you so much. And now we have Dr. Leah Shaw from Applied Sciences.
What? You can do it.
All right, so I'll talk a little bit about Ebola modeling. First of all, what are people trying to accomplish with modeling? We'd like to be able to plan, usually because we have limited resources and how do we best allocate them. Where do we need the hospital beds the most? We would like to test possible interventions through modeling.
rather than just by trial and error. So for example, in a model, you can check out certain types of isolation of patients, certain types of travel restrictions, what effect should that have on the spread, and figure out what's the most worthwhile thing to do. Because you can't do everything all at once. In real life, you only have limited resources. And so testing it in a model and figuring out what is going to work best can be a good approach. And then other modeling is done simply to figure out what data are we missing, why aren't our models working, what are the most important things to go measure so that we can have better models to do the things that I said first, the planning and testing interventions. So those are some goals. I'm going to talk about a very simple model. This is not a good model for Ebola, just to give you a flavor for what goes into epidemic modeling. This model is called SIR, stands for Susceptible, Infected, Recovered. It's for a disease like measles, childhood diseases, for example. In this very simple model, we assume that the population is large and well mixed, and then each person we have is either susceptible, infected, recovered, and we put them all in a bag and shake them up and let them contact each other. So you can see the flow diagram there shows the progression, susceptible to infected to recovered, and then there are parameters associated with each of these processes. In this case, we have birth and death, that's the rate mu, so we're putting new susceptibles into the system, because like I said, this is motivated by childhood diseases. You have some rate for susceptibles to become infected, and I'll say more about that. And then infectives recover at some rate. And so in order to accurately model a disease like this, we would need to have at least 3 parameters here. So what we do is we write equations for the rate at which all these variables are changing, susceptibles, infectives, recovers. So for example, the rate of change of infectives, we have this arrow into the box labeled I, that's the new infections, and it's going to depend on how many susceptibles we currently have and how many infectives we currently have. And so, depending on how many we have, the product of that will be the number of contacts between susceptibles and infectives. And there's some sort of contact rate, how often do people come together, and how often they come together in an infectious way where disease can be transmitted. So that's the arrow into the I box. And then we can have recovery with some recovery rate. And so the number of people flowing out of there will be our recovery rate times our number of infectives. And then in this particular disease, there's no extra mortality rate due to the disease, but people are just dying at whatever their natural rate will be anyway. So this is a simple model, and it can be translated into a set of equations. So for those who have taken calculus, you'll recognize these as derivatives. For example, change in number of infectives with respect to time. And given the flow diagram, we write these equations, and we figure out, based on these equations, over time, how many susceptibles, infectives, and recovers are we going to have. So that would be a simple model. And the quantity that Alison mentioned, this R, or R naught, the basic reproductive rate, or reproductive rate of infection, I want to say a little bit more about, because that's a very important parameter. So for this model that I showed you, it is the contact rate divided by the recovery rate. It's supposed to be the number of new cases that each infected individual will produce. And so if you have the time that you spend infected times your rate of infecting other people, that gives you how many new cases you'll make. If this number is greater than 1, each case is leading to more than 1 new case, the disease is going to propagate. If we can get this number R naught to be less than 1, the number of cases will decline over time and the disease will die out. So the goal is to do something in the system so that R naught is less than 1. We can't really change the properties of